So during this lecture, we will talk about small and large intestinal pathology. The small intestine and the large intestine form a large part of the gastrointestinal tract. The small intestine is formed, as you know, from the duodenum, jejunum, and the ileum. The large intestine, as you know, is formed of the cecum, ascending colon, transverse colon, descending colon, the sigmoid, and the rectum. And they are the site for many inflammatory, malabsorptive, and even neoplastic diseases. The small intestine and large intestine are formed histologically from the same cell tissue layers. They are formed of the mucosa, submucosa, muscularis propria, and the serosa. However, this wall thickness is thin in the small intestine while it is thicker in the large intestine. However, the lumen of the small intestine is narrower than the lumen of the large intestine. So we have a long list of diseases that can affect the intestines, whether the large intestine or the small intestine, and they are subdivided into these subcategories. Intestinal obstruction, which is a very common manifestation seen in the emergency rooms, sometimes in kids and in adults. Vascular disorders, in which we will discuss one of the commonest diseases of the gastrointestinal tract among patients, which is hemorrhoids. And we have the malabsorptive diseases. You know that the small intestine is the main site for all nutrient absorption. So diseases that affect the small intestine can result sometimes in malabsorption. And we have also the infections, and the infections will be covered in the microbiology section, not in the pathology section. So during this lecture, I will cover the intestinal obstruction and its causes, vascular disorders, and malabsorptive diseases resulting in diarrhea. Inflammatory bowel diseases will be covered in a separate lecture, and the polyps and neoplastic diseases also will be covered separately. This slide here represents the different causes of intestinal obstruction. It is subdivided into mechanical obstruction and non-mechanical obstruction, which we call it functional obstruction, like in achalasia of the esophagus. The main disease that we will talk about is hairspring disease. Mechanical obstruction can be a result of intussusception, hernias, adhesions, volvulus. I will talk about them in the next slides. And in older patients, sometimes also tumors, diverticulitis, and infarction or ischemia can cause obstruction. It is important to know the clinical picture of intestinal obstruction. When you have an obstruction to the passage of a stool in the intestine, and the most common site for intestinal obstruction is usually the small bowel. It is more commonly affected than the large bowel because of the small diameter of the lumen. The symptoms are predominated by abdominal pain and distension due to gaseous distension. In addition, the patient is also complaining of vomiting and constipation. And intestinal obstruction can present as an acute problem of sudden onset, like in the cases of intussusception or volvulus or infarction, but it also can present as a chronic, long-standing problem, like in the cases of hairspring disease or in the cases of tumors. So here in this picture, you can see the most important or the most common causes of mechanical obstruction that are seen in 80% of the cases, which are the intussusception, the herniation, adhesions, and volvulus. Intussusception will be covered in details in the next slides. And it is usually seen in kids or in children. Hernia, or what we call it الفتق, it is a protrusion of the bowel segments and its mesentery through a defect in the usually in the abdominal wall. We have
umbilical hernia, femoral hernia, inguinal hernias, and in all of these, a part of the bowel is trapped in the hernial sac, and there will be obstruction. And in some cases, it will be complicated by infarction of this bowel segment. Adhesions, the adhesions is التصاقات, which can occur between bowel segments, and usually it is a complication of a previous inflammatory condition in which there is a scarring after the inflammation, and sometimes after surgical procedures at the sites of previous surgery, complicated by fibrous scarring and adhesion between two bowel loops. This adhesion will result in mechanical obstruction. Another cause of mechanical obstruction is volvulus. Volvulus, or it's like torsion of the intestine, التواء, in which we will have impaired venous drainage, stasis, edema, and congestion, and can be complicated later on by infarction and ischemic damage to the bowel. So what is intussusception? Intussusception is the most common cause of intestinal obstruction in children under the age of 2. And it happens when a segment of the bowel that is constricted by a wave of peristalsis telescopes or enters into an immediately distal segment that is wider in its diameter. So a constricted segment enters or telescopes into a wider distally located segment, and with each peristaltic contraction the proximal segment enters more within the wider distally located segment and is propelled by these peristaltic contractions, pulling with it the mesentery surrounding the bowel. If left untreated, the intussusception will progress to infarction. So again, intussusception is the most common cause of intestinal obstruction under the age of 2. And in most of the cases, it is idiopathic, meaning that there is no underlying cause. However, in other cases, the cause is usually lymphoid hyperplasia, that is Peyer's-Bach's hyperplasia, which is usually associated with viral infection or with the rotavirus vaccine. The rotavirus is responsible for most cases of viral gastroenteritis in childhood. Also, another cause in this age group is Meckel's diverticulum, which is a diverticulum that is located in the ileum, and it is a congenital diverticulum. These areas of Peyer's-Bach's hyperplasia or Meckel's diverticulum can be the leading point for starting the intussusception process. In older children or in adults, you have always to suspect an intraluminal mass or a tumor to be the leading cause of intussusception, because intussusception is not common at that age group. So whenever we see an intussusception in an adult, we should think of an underlying cause or mass or a tumor as the leading point for the intussusception. When we suspect intussusception, especially in the children under the age of 2, you suspect it when you receive a child to the emergency room complaining of abdominal swelling and distension associated with vomiting and passing of stools that are mixed up with blood and mucus, and it is typically called a currant jelly stool. This is a typical description for the appearance of the stool in these patients. So a patient in the emergency room, he's a kid with abdominal swelling and distension, vomiting, and passage of blood and mucus colored mucus mixed stools. If the patient is older, he can complain of pain, but in the case of patients under the age of 2, the pain is usually expressed by continuous crying and grunting. So when you see these symptoms in a kid under the age of 2, you should have a high index of suspicion for intussusception, because an early identification of the case and early management will save the patient.
Now, regarding the management of intussusception, it depends on the degree or the stage of the disease. Like if it is early and still not going into infarction, and these are called uncomplicated cases, we can use contrast enema أو ما يسمى بالحقنة الشرجية. وبالتالي لما تدفع هاي الحقنة الشرجية through the rectum راح يصير في reduction لهذا الانتسسبشن. ولكن في حالات اللي بتكون complicated وصار infarction of the bowel segment, we need إن نتدخل بشكل جراحي. So surgery is needed if it is complicated, like if with super added infarction أو إذا في mass هي leading points زي في الادults أو older children. Now we turn into one of the functional obstructive causes in the intestines, what is called Hirschsprung disease. Hirschsprung disease is a congenital disease, which means the baby is born with this disease and there is a defect in the innervation of the colon, in the intrinsic nervous system of the colon, specifically the ganglion cells اللي بيكونوا موجودين in the submucosa and between the two muscle layers. This disease is called congenital aganglionic megacolon. Congenital because it is a congenital disease the baby is born with and it's not acquired. Aganglionic because upon microscopic examination of any biopsy from the colon, we have no ganglion cells demonstrated, and megacolon because in these patients the colon is remarkably enlarged and dilated. It's more common in males, it's more severe in females, and the risk increases in siblings. So if you have one family member affected, the risk is increased in the other family members. The typical presentation for Hirschsprung disease in the baby fails to pass the meconium, neonatal failure to pass meconium. الميكونيوم هو the first stool that pass after delivery of the baby. فهدول البيشنتس يا اما بيتاخروا في الباسج of meconium أو there is failure يعني ما بصيرش passage at all of this meconium. Later on البيشنت بصير عنده برضه obstructive constipation. Constipation means إمساك، فإما بيكون ال number of bowel motions per day بيكون قليل أو حتى ال consistency of stool بتكون مختلفة، فبيكون very hard stool and very difficult to pass. Excluding organic causes of obstruction, like there is no intussusception, there is no tumors, there is no hernias, بنصير نفكر إنه this could be a functional obstruction or Hirschsprung disease. فالindex of suspicion لازم يكون عالي لما ينولد البيبي ويصير عنده failure to pass meconium. This is a very important clue in Hirschsprung disease أو إذا كان حدا في الفاميلي affected.
So what is the pathogenesis of Hirschsprung disease? The pathogenesis starts during embryogenesis, in which there is a defect or a failure of migration of the neural crest cells from the cecum to the rectum. And so the result is lack of development of the neural plexuses that are usually present within the rectum. The disease affects the rectum in almost all of the cases. However, the length of the affected segment is different from one patient to another according to the severity of the disease. So the end result due to failure of migration of these neural crest cells is that a segment of the bowel will have absence of submucosal nerve plexuses and myenteric nerve plexuses. So we will lose the enteric nerve plexus or neuronal plexus at the affected site. And the result of this absence of these plexuses is lack of peristaltic contractions or lack of coordinated peristaltic contractions, which will result in the most important symptom of this disease, which is constipation due to lack of peristalsis. So at the end, we have an area of the bowel that lacks innervation by the enteric neuronal plexuses due to the failure of the migration of these neural crest cells from the cecum to the rectum during embryogenesis, and this segment will have lack of peristaltic contractions and the resultant constipation. Now, the familial cases of Hirschsprung disease, they share a mutation in the RET gene, and also this gene is mutated in a subset of the sporadic cases. Other genes are also implicated and some environmental factors. So again, the main feature of Hirschsprung disease is that we have a segment of the bowel that lacks innervation and lacks the development of the enteric neuronal plexuses, namely the myenteric plexus and the submucosal nerve plexus. And that's why the disease is called aganglionic, because we don't have the ganglion cells that are typical for these plexuses in the affected segment. In Hirschsprung disease, the rectum is always involved. However, the extent of the disease or the length of the involved segment of the bowel is variable and it differs from one patient to another. Most cases are in the rectosigmoid area. However, in very severe cases may involve the entire colon. So the affected area with aganglionosis, in which we don't have ganglion cells, this area will look normal or contracted or on barium enemas. The proximal normal segment, normally innervated bowel segment, will undergo progressive dilatation. So we will have a megacolon in the normally innervated segment and a normal or contracted caliper in the aganglionic segment. You will see the barium enema in the next slide, in which you will see the contracted segment. The aganglionic segment will look contracted and the normally innervated segment will look progressively dilated, like what we see in achalasia with progressive dilatation of the esophagus. Now, how we diagnose Hirschsprung disease? The diagnosis is a combination of clinical features in which we have a child with a failure to pass meconium, for example, or a child complaining of a chronic constipation in which we fail to find a cause for this constipation. The barium enema will help us in the typical characteristic feature of contracted aganglionic segment and a dilated normally innervated segment, but the gold standard for the diagnosis is the biopsy. Usually a rectal full thickness biopsy is used for diagnosis, in which we will establish the absence of the ganglion cells in the myenteric plexus and in the submucosal plexus. And this process is not easy because usually we need to examine multiple deeper levels from the rectal biopsy to be sure that there is no ganglion cells, because when you say to the surgeon that this is Hirschsprung disease or you don't see ganglion cells in the biopsy, this will have a serious outcome on the patient. The patient will undergo resection of this aganglionic segment until we reach the area with normal innervation, and then anastomosis of the normal segment to the distal part of the rectum. So the diagnosis is not easy, and the gold standard for the diagnosis is the is the demonstration of the absent ganglion cells on the rectal biopsy. Here you can see the microscopic appearance of Hirschsprung disease. You can see the contracted rectum and the progressively dilated proximal normal segment, and the adjacent picture illustrates the barium enema with a contracted rectum and a dilated proximal colon.
Now, these are the ganglion cells, which we keep looking for them in the biopsies from patients with suspected Hirschsprung disease, not the abundant cytoplasm with eccentrically relocated nucleus and prominent nucleolus.
What are the complications of hairspring disease? Enterocolitis, because we have a stasis of a stool in the bowel, and this will place the patient for the risk of enterocolitis, infectious enterocolitis. Also, there will be fluid and electrolyte disturbances, sometimes dehydration. The dilated megacolon is under the risk for perforation and peritonitis. The treatment, as I said, is resection of the aganglionic segment after being sure of the diagnosis, and anastomosis of the normal segments together. And the patients usually do well, but they need time to be adjusted to the to the new situation after the surgery. After discussing the intestinal obstruction, we move to vascular disorders of the bowel, which are divided into ischemic bowel disease, which is a result of ischemia, or loss or decreased blood supply to the bowel, whether it is acute or chronic. And usually ischemic bowel disease is seen in older subjects and old elderly patients. The second vascular disease, which is a common problem in outpatient clinics, is the hemorrhoids. The other vascular disorder of the bowel is the hemorrhoids. The hemorrhoids are dilated veins, submucosal veins in the anal and rectal mucosa. The pathogenesis of hemorrhoids is similar to the pathogenesis of esophageal varices. They occur in association also with portal hypertension because, as I explained earlier, the anorectal area is the site of the portosystemic anastomosis or portosystemic shunts. So hemorrhoids are dilated veins in the submucosal location in the anal area or the rectal area. And the hemorrhoids are subdivided into internal hemorrhoids and external hemorrhoids according to the location. If it is below the anorectal line, it is called external hemorrhoids, and if it is above the anorectal line in the rectal mucosa, it is called internal hemorrhoids. The predisposing factors for hemorrhoids, as I said, portal hypertension is an important predisposing factor, with the causes of portal hypertension being like liver cirrhosis or schistosomiasis. Other causes, common causes of hemorrhoids are the chronic constipation and straining, which will increase the intraluminal pressure within the rectum and cause dilatation of these veins. Also, venous stasis of pregnancy is an important cause of hemorrhoids. Being thin-walled and in a submucosal location places these vessels under the risk of rupture or abrasion and the resultant bleeding. So the symptoms of hemorrhoids is mainly bleeding, and usually the blood is fresh colored, red blood. If it is complicated by thrombosis or inflammation, the patient also will complain of pain. So hemorrhoids are typically associated with bleeding, of fresh blood, and pain. So here we come to another important manifestation of intestinal diseases, which is called diarrhea. Diarrhea is defined as increase in stool mass, frequency, or fluidity. So any one of these is enough to call it diarrhea. Either increase in the mass or the frequency of passage of a stool or the fluidity of the stools. Another definition that you have to know is called dysentery. Dysentery is painful with مع ألم, bloody, small volume diarrhea. Diarrhea as a manifestation of intestinal disease can be caused by a variety of causes, and it is subdivided into malabsorptive diarrhea, infectious enterocolitis or infectious diarrhea, and chronic inflammatory bowel diseases. In addition, sometimes ischemic colitis can result in diarrhea and some nutritional deficiencies. But the most common causes are malabsorptive diarrhea, infectious enterocolitis, and chronic inflammatory bowel diseases. The infectious enterocolitis will be covered in the microbiology section, and we already covered inflammatory bowel diseases in a separate section. The malabsorptive diarrhea will be covered during this lecture, and the causes are diverse. It can be caused by pancreatic insufficiency, celiac disease, and Crohn's disease. And these three diseases are the most common causes of of chronic malabsorption in the Western countries. Pancreatic insufficiency due to lack of pancreatic enzymes, and celiac disease مرض تحسس القمح, and Crohn's disease, which is one of the inflammatory bowel diseases, as we mentioned in the CIBD lecture, which can result in malabsorption because it affects the small bowel and the terminal ileum, the site for absorption of many nutrients, especially vitamin B12, proteins, and albumin and bile salts. Another cause of malabsorptive diarrhea is cystic fibrosis, which is a disease called التليف الكيسي, cystic fibrosis. It is caused by a genetic mutation. Another cause of malabsorption is lactase deficiency, a common cause of diarrhea caused by deficiency of the enzyme needed for the digestion of the disaccharide lactose, سكر الحليب. And another cause is A-beta lipoproteinemia. So all of these are diverse causes of diarrhea, and they differ somehow in their clinical presentation. So malabsorptive diarrhea is a chronic diarrhea. هي إسهال مزمن, and it is a result of the defective absorption of many nutrients like fat and water soluble vitamins, proteins, carbohydrates, electrolytes, minerals, and water. So absorption of all of these substances can result in chronic diarrhea. The hallmark of malabsorptive diarrhea is called steatorrhea. Steatorrhea is the greasy, fatty, bulky, yellow-colored or clay-colored stools that is typical for malabsorption. The malabsorptive nutrients or materials are all are accumulated in the stool, and they gave the stool this greasy, fatty, yellow discoloration. So it is called steatorrhea, and it is the hallmark of malabsorptive diarrhea. The mechanisms by which malabsorptive diarrhea develops is due to a defect in one of the following functions. It is either a defect in the intraluminal digestion of the large nutrient substances like fats, carbohydrates, and the proteins, and usually this is as a result of the main enzyme deficiencies like pancreatic deficiency. So a defect in the intraluminal digestion of the large molecules. The second defect is in the terminal digestion. The digestion of the end products of the carbohydrates or the proteins like the small disaccharides or the small peptides, which is usually associated with deficiency of some disaccharadases and peptidases, which are usually seen at the brush border of the small intestine, like lactase deficiency. The other defect is in the transepithelial transport of the nutrients through the epithelial cells in order to reach the other side, or the vascular side. And the last defect is in the lymphatic transport of the absorbed lipids, because absorbed lipids usually are transported through the lymphatics to the systemic circulation. So any defect in one of these steps, the intraluminal digestion, terminal digestion, or transepithelial transport, or lymphatic transport, can result in malabsorption. And in fact, sometimes more than one mechanism can act at the same time. Now, the manifestations or the clinical signs and symptoms of malabsorption differs according to the substance that is being malabsorbed. But in general, all malabsorptive diseases share common manifestations. One of the most important manifestations is weight loss. Due to the lack of absorption of proteins and carbohydrates and fats. Anorexia, it is loss of appetite. So malabsorptive diseases can result in loss of the appetite. Another manifestation is flatus or abdominal gaseous distension. This is a common manifestation of malabsorption because of due to the malabsorption of disaccharides or carbohydrates. These materials stay in the intestinal lumen, and the normal flora and the bacteria acts upon them and causes their fermentation with the production of gases, and this will result in abdominal gaseous distension. Another manifestation is borborygmi. Borborygmi اللي هي الأصوات اللي ممكن نسمعها للمعدة والأمعاء due to the presence of gas within the bowel lumen. And also muscle wasting in which the main muscles, they look like atrophied. We call it muscle wasting. Another manifestation is the anemia and mucositis, and the anemia can be caused by iron deficiency or vitamin B12 deficiency or folate deficiency. Mucositis, which is inflammation of the mucous membranes at the angle of the mouth, and also it can be caused by iron deficiency, folate deficiency, and the vitamin B6 or pyridoxine deficiency. Also, deficiency of the fat-soluble vitamins like vitamin K can result in a bleeding tendency, because vitamin K is needed for the thrombotic cascade. And the deficiency of vitamin K can result in bleeding, nazif. Also, malabsorption of calcium, magnesium, and vitamin D can result in osteopenia ونقص في كثافة العظم، وأحيانا osteoporosis وهشاشة عظام على عمر مبكر, in addition to tetany. Malabsorption of vitamin B12 and vitamin A can result in neuropathy and neurological manifestations like peripheral numbness, خدران في الأطراف, or burning sensation in the hands and feet, and also muscle weakness. Also, skin and endocrine disorders can result from the malabsorption of substances that are needed for the skin development or and for the hormone synthesis, like deficiency of iodine, or malabsorption of iodine can result in the thyroid hormone deficiency. Cystic fibrosis is one of the diseases that cause malabsorptive diarrhea. Cystic fibrosis أو بيسموه التليف الكيسي, it is a multi-organ system disease with a genetic basis. So the disease affects the lungs, affects the pancreas, and affects the intestines. And the main genetic defect in the CFTR, which is called the cystic fibrosis transmembrane conductance regulator. Mutations in this gene can result in a defect in the ion transport across the epithelium of the intestine and across the pancreatic epithelial ductal cells. And due to the defect in the ion transport, and you know that always the movement of ions like sodium is accompanied by movements of water. So when there is defect in the transportation of sodium across these membranes, water will not follow the sodium, and the secretions from the pancreas will be highly viscous and high and thick secretions, which can cause mucus plugs within the pancreatic ducts, leading to blockage of these ducts, and the pancreatic enzymes will not reach to the intestine, so causing pancreatic insufficiency in 80% of patients with cystic fibrosis. The result of pancreatic insufficiency is defects in the intraluminal digestion, and the end result will be malabsorptive diarrhea.
Now we come to celiac disease, one of the most important malabsorptive diseases involving the intestine. والاسم الثاني له هو الجلوتين sensitive enteropathy. هو حساسية القمح، وبالذات الكومبوننت من القمح أو الحنطة أو الشعير wheat, rye or barley. الكومبوننت اللي بيكون له sensitivity أو حساسية هو الجلوتين. It is an immune mediated enteropathy. تفاعل أو يعني مرض مناعي، وفي genetic predisposition عالي فيه و associated with certain HLA types اللي هم DQ2 و DQ8. This is a very well documented association. طبعا بما انها هي حساسيه ضد الجلوتين، the most important part of the treatment is the gluten-free diet. It's very difficult to stick to this gluten-free diet, but nowadays there are many gluten-free products available in the market. The problem is with the kids, they cannot stick well to this diet. طبعا this treatment will reverse the clinical manifestations and even the microscopic manifestations اللي راح نشوفهم كمان شوي typical finding في ال small intestine of these patients. بما إنه immune mediated disease فإله association with other immune mediated disorders like type 1 diabetes mellitus, with cases of thyroiditis and Sjogren syndrome. Now, the pathogenesis of celiac disease, in summary, includes an immune-mediated reaction toward the gluten اللي موجود في الدايت. هلا normally the gluten is digested in the bowel into gliadin. Now, this gliadin is a short peptide which is resistant to the digestion by the pancreatic enzymes, gastric, and intestinal enzymes. So this gliadin is deamidated by an enzyme called tissue transglutaminase, TTG. Now, this tissue transglutaminase leads to the formation of deamidated gliadin. This deamidated gliadin will enter into the lamina propria of the small intestine. What happens that if the patient is inheriting these HLA subtypes DQ2 and DQ8 and these HLA subtypes are presented on the antigen presenting cells in the lamina propria of the intestine, there will be activation of these antigen presenting cells with activation of T cells, principally the T helper cells, CD4 positive cells, which will activate an inflammatory reaction or production of cytokines and inflammatory mediators that will lead to tissue damage. التيشو damage اللي بيصير بالceliac disease هو mainly the loss of the villus architecture اللي هو ضروري عشان يعطي large surface area for the absorption of nutrients. So there will be loss of this villus architecture with the conversion into a flat mucosa. السيرولوجيك ماركرز اللي بتكون موجوده بهدول البيشنتس هم الانتي تيشو ترانسجلوتامينيز انتي بودي وانتي جليادين انتي بودي وانتي اندوميزيل انتي بودي، وهو مش معروف لحد الان بالضبط هل هم the result of the disease أو ولا هم the cause of the disease. But they are elevated in these patients and they are used in the diagnosis and in the monitoring of the response to treatment because they are supposed to decrease and decline after 3 to 6 months of gluten-free diet. Now, this illustration here describes what I have said in the previous slide. Note that the main change in celiac is the loss of the villi of variable degrees. Now, regarding the morphology of celiac disease, it's mainly the disease affects the second part of the duodenum with the proximal jejunum. So if we need to diagnose the celiac disease and we suspect it based on the clinical picture والhistory والأعراض اللي عند المريض ونعمل endoscopy, if you need to take a biopsy to confirm the diagnosis, we need to take it from the second part of the duodenum, not the first part. The first part بالعادة بيكون معرض للأسيدك content of the stomach وبالتالي في inflammation بطبيعة الحال فما بقدر أعتمد عليه بتشخيص الceliac disease. The diagnosis of celiac disease is not an easy diagnosis. We have to correlate the clinical features with the serologic findings, the serologic antibodies in the serum if they are elevated بالإضافة للendoscopic والbiopsy findings. The histologic during endoscopy الطبيب بيشوف second part of the duodenum ممكن يشوف فيه atrophy أو في furrows in the mucosa with the loss of the villus surface and loss of the folds. Under the microscope we need to see a triad ولكن مش دائما الترياد بيكون كله موجود. The earliest manifestation هي الانكريز بالintraepithelial lymphocytes وهدول الليمفوسايتس زي ما حكينا بيكونوا CD8 positive T cells بيكونوا موجودين in between the epithelial cells on the lining mucosa بالإضافة إلى crypt hyperplasia اللي بتصير نتيجة الدمج فبصير increase بالturn over of the epithelium بالإضافة إلى most important feature اللي هي villus atrophy which can be total in severe cases or subtotal or partial or villus shortening. The lamina propria shows infiltration by inflammatory cells, lymphocytes, plasma cells, and eosinophils. The lymphocytes in the lamina propria are mainly T helper cells. So I may not see the whole triad, but this is the classical scenario. The intraepithelial lymphocytes and the villus atrophy are not pathognomonic for celiac disease, so they can be seen in other forms of, for example, viral enteritis can cause intraepithelial lymphocytosis with villus atrophy. So the diagnosis is not only based on the microscopic appearance. We have to take the patient as a whole, the history, the malabsorption, the endoscopic findings, the serologic findings, and the histologic findings in the biopsy, which is the gold standard at the end to diagnose, plus the response to the gluten-free diet is a clue for the disease. So you can see here the difference between the normal duodenum with these long cylindrical villi like finger-like projections and the mucosa in celiac disease in which it is here totally flat with total loss of the villi. Now بالنسبة للclinical features of the disease can affect the children as well as adults. Children usually presents after 6 months of age. Why? Because we can't have the disease before the administration of a gluten diet, containing diet. So it's the time when the child starts to eat food rather than milk is 6 months. So the symptoms can be classical or non-classical symptoms. The classical symptoms involves irritability, abdominal distension, gaseous distension, anorexia, loss of appetite, diarrhea, very important, and because it's a malabsorptive disease, failure to thrive and failure to gain weight, failure of the growth of the child with weight loss and muscle wasting. The non-classical manifestations هدول أحيانا ممكن يضيعونا شوي لأنه they will not point to celiac disease يعني ما في diarrhea ما في weight loss بس البيشنت بيجي abdominal pain, unexplained, nausea and vomiting, bloating, sometimes constipation rather than diarrhea. So these manifestations can sometimes delay the diagnosis. In 10% of patients ممكن يكون associated معاهم blistering skin disease in which there is a lot of blisters, skin rash that is itchy, بيشبه الهربس simplex virus, and it is called dermatitis herpetiformis, but it is not viral. It is an immune mediated also skin disease associated with celiac disease. This is the typical manifestation of dermatitis herpetiformis بيشبه الهربس simplex. As you can see here, there are many vesicles that are fluid filled وبتكون very itchy to the patient.
In adults, the disease typically presents between the age of 30 to 60 years. The typical presentation is with malabsorption. Anemia that is typically iron deficiency anemia because the duodenum and the proximal jejunum are the main sites for the iron absorption. Vitamin B12 and folate deficiency anemias are less common because, as you know, the vitamin B12 and is being absorbed in the distal small intestine, principally in the ileum, which is usually not affected in a patient with celiac disease. The main classical symptoms in an adult is abdominal gaseous distension, weight loss, muscle wasting, diarrhea or steatorrhea, bloating, and fatigability, usually due to the iron deficiency anemia. However, sometimes the diagnosis of celiac disease can be missed or can be delayed due to a silent disease or a latent disease. A silent disease means that a patient have a positive serology for the celiac, and if we do a biopsy, he will show villus atrophy. So we have a histological diagnosis and a serologic diagnosis. However, the patient is asymptomatic, but meanwhile, maybe later on the patient will start to develop or to complain of the symptoms of celiac disease later on. Latent disease, it means that the patient have a positive serology. However, histology is normal and symptoms are absent. And this is called latent disease. These cases of silent disease or latent disease may develop the full-blown picture of celiac disease later on. The most important in patients with celiac disease is that they have an increased risk of certain type of lymphoma, which is called enteropathy-associated T-cell lymphoma, and even there is an increased risk of small intestinal adenocarcinoma. So a patient with celiac disease have an increased risk of lymphoma and small intestinal adenocarcinoma.
Now, again, how we diagnose celiac disease, we depend on the history of the patient. The patient comes to you complaining of, for example, an unexplained iron deficiency anemia in an adult, or a baby not gaining weight, failure to thrive. So you start with the diagnostic modalities. We start with non-invasive tests اللي هي السيرولوجيك test to detect the antibodies. في عندنا sensitive antibodies وفي عندنا specific antibodies. The most sensitive antibodies هم anti-tissue transglutaminase antibody, which is an IgA antibody in the blood, and the anti-deamidated gyridine antibodies IgA and IgG. لكن هدول السنسيتيف بس مش specific. The more specific هو الانتي اندوميزيال antibody، ولكن مشكلته انه مش sensitive، مش موجود في كل الحالات. So the best way to start with is to do all of these antibodies, or start with the most sensitive ones and then تنتقل إلى المور specific one. If they are positive, then the patient is designed for endoscopy, and بالendoscopy بنشوف الduodenum والproximal part of the jejunum, and we take a biopsy, preferably from the second part of the duodenum, and preferably multiple biopsies because the disease can be sometimes focal. We establish the diagnosis on the biopsy by the histologic findings اللي حكينا عنهم اللي لازم نشوفهم، وكمان ممكن نعمل follow up للresponse for the gluten free diet، بحيث انه antibodies they should decline, and even the histologic changes should be reversed back to normal. إذا البيشنت تحول لبيشنت refractory to treatment أول إشي بنفكر فيه ال non-compliance with the treatment و non-compliance with the gluten-free diet. بس إذا ال patient compliant with the diet وبلش يصير refractory لهاي الدايت، يعني ما عم يستجيب والsymptoms رجعت، لازم نفكر إنه صار في complication like lymphomatous transformation for example or adenocarcinoma بعد سنوات من ال disease. So we come to another cause of malabsorptive diarrhea, lactase deficiency or disaccharidase deficiency. It is a cause of osmotic diarrhea. What is lactase? Lactase is the enzyme اللي موجود على ال brush border, ال apical brush border of the small intestine واللي هو مسؤول عن ال splitting the lactose sugar in the bowel. The lactose في هاي الحالة لأنه ما في لاكتيز انزيم راح يضل موجود في الجت لومن وراح يسحب معاه ووتر ويعمل لي اوزموتيك دياريا. هدول البيشنتس بتيجي بتعملهم endoscopic biopsy because they present طبعا with diarrhea وabdominal distension. فبتعملهم bowel biopsy or duodenal biopsy. The biopsy is normal because the problem is at the biochemical level, at the brush border enzymatic deficiency. We have two types of lactase deficiency. The first one is congenital, which is an autosomal recessive, results from a genetic mutation, and it's rare. The patient here presents with this explosive diarrhea, which is watery, frothy, with abdominal gaseous distension، وهذا طبعا كلياته بصير بعد الميلك ingestion. The more common subtype هو acquired subtype اللي بالعادة follows viral or bacterial enteritis خاصة في الأطفال، وأحيانا ممكن يجي برضه after childhood نتيجة ال down regulation of the genes encoding the lactase enzyme، لأنه بيصير يعني بيقل ال ingestion of milk فبصير في down regulation للجين، فممكن ال patients لما يرجعوا يشربوا الميلك milk products يصير عندهم ال symptoms. Another malabsorptive disease is called A-beta lipoproteinemia. The name implies the meaning of the disease in which there is no beta lipoproteins in the body. These beta lipoproteins are synthesized from the reaction between the lipids اللي هم triglycerides والfatty acids with the proteins to form the beta lipoproteins. This disease is autosomal recessive and it's very rare and usually affects infants. فبيجوا infants during the first year of life, failure to thrive, failure to gain weight, marked diarrhea with steatorrhea. البروبلم بهذا الديزيز انه في عنا defect بيؤدي للاck of absorption of fat and fat soluble vitamins. فهذا الفات والفات soluble vitamins بيدخلوا لداخل الخلايا، لكن في مشكلة في الترانس epithelial transport. فthese triglycerides and fatty acids they accumulate in the epithelial cells of the bowel. The monoglycerides, the triglycerides, the fatty acids accumulate inside the cell وما بيقدروا يدخلوا للبلد. فبالتالي the body cannot synthesize the lipoproteins, the triglyceride rich lipoproteins، فبيكون يعني there is a deficiency of these lipoproteins in the body. So this is the typical microscopic findings that we see upon taking a biopsy from the bowel, from the small bowel. This is the normal side here, as you can see the cells with the eosinophilic cytoplasm, but here the cells have a clear cytoplasm اللي هو الأبيض. This indicates the accumulation of fat and lipid inside these cells لأنه بيدخل الفات لكن ما بيقدر يدخل للبلد أو ينتقل للبلد. This is characteristic for A-beta lipoproteinemia.